Yeah. Let's have a look. It's still there. We go. We're live. Hello, everyone. Welcome to this final session of this sort of short revamp of the Mind the Bleep Neurology Series. My name's Alex. I'm the sort of neurology lead for Mind the Bleep, and have coordinated the last year and a half's worth of webinars. And I'm currently a clinical fellow at Southmead Hospital in Bristol, on the edge of the southwest of the UK. And tonight, very pleased to introduce Dr. Ameen Noushad, who finally, I can see the presentation was working then, Ameen.
I think it's fine. Now,
yeah.
should hopefully come now. Yeah.
Let's have a look. There we go. But Ameen is an ST4 neurology registrar in Plymouth, as all the other previous presenters have been. And he's going to talk to us tonight about neuroinflammatory disorders. So, Ameen, over to you.
Hi, everyone. Thanks very much, Alex, for introducing me. And I just want to give a brief overview about different neuroinflammatory conditions, because oftentimes, there's a lot of neurophobia in general, and especially in regards to neuroinflammatory disorders, there's even more neurophobia, even among neurology registrars. So that's the reason why I thought, probably make it, as succinct as possible so that we have an understanding of what we mean by neuroinflammatory disorders. So in terms of the aims of the talk, I'm going to cover different common neuroinflammatory conditions and talk about the different clinical phenotypes that we can see. Then the other thing that we are going to talk about is, sort of the difference between MS, neuromyelitis optica, MOG disorders, and something what we call ADEM, and we'll talk about this in detail. Now, I'm not going to be talking about MS therapies in detail or other neuroinflammatory conditions, because that's beyond the scope of this talk. Now, let's start with a case. Now, you are a F1 or an SHO in ED. Now, there's a referral to you from GP saying there's a patient, young patient, a 50 or 35-year-old patient coming in with an internuclear ophthalmoplegia, and there's an abnormal MRI suggestive of MS. So now, if I were to ask you, if I were to ask anyone, I know it's a bit difficult to shout out loud, but if you could type in the message as to where the internuclear ophthalmoplegia could be and where the lesion could be essentially on the MRI, that would be quite helpful. If you don't know, it's absolutely fine. Or if you don't know what internuclear ophthalmoplegia as well, that's absolutely fine. That's not a problem. So there is a particular location that we look for on the MRI essentially. And let's have a quick look as to where this could be. Now, this is one of the common areas. I hope that you can see that small tiny dot over there. So that's the pons essentially. Now, in the pons, there's a particular area called the medial longitudinal fasciculus. Now, the idea behind internuclear ophthalmoplegia is that, now suppose that, let's say I am looking to the right. You need my right eye and my left eye to look in a manner that is sort of, together it needs to look to the right in a coordinated manner so that I can successfully look to the right. So how does that work? So the signal needs to go from the right eye, so specifically the right sixth nerve, and the left third nerve should be, sort of working together at the same time. And the connection happens at this point where the MLF is. So now in this particular patient, as you can see, when this patient is trying to look to the left in general, there's no movement of the right eye. And that's one classic thing that you can see with internuclear ophthalmoplegia. So there's no problem with the abduction of the right eye. And then there is, I think there's no problem with the left eye, and there's a problem with the right eye. But if you were to ask the patient to look to the other side, that is the right side, this patient would not have any problems at all. All right. So that's one of the common lesions that you can see. And it can be a presentation in MS or a first presentation of MS, so like a clinically isolated syndrome. So that's the reason why I thought we'll discuss about this. Now we'll continue with this case in detail. Now we'll talk about some of the common neuroinflammatory disorders. Now, what are the common neuroinflammatory disorders? Like there's MS, NMO, ADEM, anti-MOGAD, and there are some other conditions like neurosarcoidosis and Behçet's disease as well. Now, as I said, I won't be covering neurosarcoid or Behçet's. But before going into the depths of MS as such, now let's talk about the different clinical phenotypes, all right? Now, somebody answered optic neuritis. So optic neuritis can be a presentation in any of these, disorders. Now, what is optic neuritis? It's not a diagnosis, isn't it? It's a clinical phenotype. But we need to find out what the underlying cause is for the optic neuritis. So basically, what does it mean? It just means there's inflammation of the optic nerve. Now, what's the most common presentation of optic neuritis? Right? There's normally what will happen is the patient comes to you, says that I've got painful vision loss that's happening slowly over hours to days. It's worse on eye movement. My pain is worse on eye movement, and time course is the key. Now, if it is this sort of a presentation that is acutely happening but progressing over hours to days, it's likely optic neuritis. But if it is insidious, think of a mass lesion. Now, where does the mass lesion? Mass lesion could be anything around the optic nerve. It could be a meningioma, it could be a tumor, anything could be there. What about if it is very hyperacute? Then we have to think about a stroke. But in the absence of all of that, then it's likely that it's an inflammatory process. Now, it can be bilateral, but the classical inflammatory presentation of optic neuritis is mostly unilateral. If it is bilateral, we have to think about other causes much more actively. All right. Now, what are the other findings that you can see? You'll have decreased visual acuity, you'll have an afferent pupillary defect, and a color vision abnormality as well. And you'll have something known as red desaturation, where basically the patient is unable to appreciate the red color. The red color appears a bit pinkish with a pinkish hue. All right. And what is an afferent pupillary defect? You might have read about this or seen it in medical school, where we do the swinging flashlight test. And basically, the idea is that when you move this flashlight from one side to the other, there should be constriction, and the constriction should remain. But on the other hand, if there is dilatation happening in the absence of constriction, then you are thinking about an afferent pupillary defect. Now, what the fundus examination can sometimes be normal in optic neuritis patients, but you can see optic disc swelling, or you can see a bit of pale disc in case there has been attacks in the past. But if it is retrobulbar, if it is behind the bulb as such, behind the globe of the eye, and it's essentially the optic nerves behind the eye is affected, you might not see anything at all. Now, like I said, it is inflammation of the optic nerve. There are other causes as well, but if it is not presenting like a classical inflammatory picture in that way, the history is key here, guys. Okay, so if it's not presenting like that, then we have to think about other causes. Like some infections can cause this. Like there is a particular infection called as cat scratch disease caused by Bartonella that can sometimes cause this. Syphilis can sometimes cause really bad optic neuritis, and it can be one of the presenting features of neurosyphilis. Now, there are some paraneoplastic causes as well that can be associated with this particular antibody called CRMP5 as well. And there are other systemic inflammatory disorders, like I mentioned earlier, like sarcoidosis, which can cause a really bad bilateral asymmetric optic neuritis that really gets worse so quickly. So the key thing is that the optic neuritis of MS or inflammation in general, like it's quite benign. It's not too bad. It doesn't get really, really bad as such. All right. Now, most patients will recover significantly, and continued recovery may occur over subsequent months. Now, treatment with IV steroids is generally recommended because it just helps with the recovery quicker, but there's no change in the overall prognosis as such. Now, optic neuritis can be a first flare of MS, or it can be a clinically isolated syndrome. Now, this is the key thing, guys. 15 years after optic neuritis, 50% of patients can develop MS. Now, the risk entirely depends on whether MRI changes are there in the rest of the brain or not. Okay. Now, like I mentioned, remember the case that I mentioned. I just showed one slice of the MRI. I'll show you more pictures of the MRI so that we have an understanding of how to approach this. Now, what are the others? What are some of the other causes of optic neuritis? It can be ischemic. And like I said, it can be paraneoplastic, or it can be infectious, like I mentioned earlier. It can also be systemic. So it's important to get a review by the ophthalmologist as well, to consider all these other causes after you suspect a patient with optic neuritis. It's really important. And also it's important to get an MRI done. And specifically, you need to get MRI of the orbits, MRI of the brain, and ideally you need to do it with contrast as well. And if you have a high suspicion for MS, then you'll have to get MRI of the spine as well. The idea is that it's not because we are localizing the lesion to any of these locations, but because these MS lesions, there might be evidence of attack in the past, and it's important to look for it by getting these MRIs done appropriately. Now, let's go to the next clinical phenotype. Now, what is transverse myelitis? Now, again, essentially, it's just inflammation of the spinal cord. Now, so that can have quite a lot of differentials, isn't it? If you have a myelitis or myelopathy that is happening very quickly, sudden onset, we have to think vascular. But on the other hand, if it is acute onset and progressive, then we'll have to think of other causes as well. It could be infectious, especially if you have a travel history that is suggestive of patients, possibly getting exposed to an infectious cause, or if it is something else entirely, like if it is, let's say, if it is an abscess formation, is there, this patient having a neurosurgical procedure, like let's say a lumbar surgery done, and then the patient is getting a progressive acute onset weakness, we don't think about inflammation as such, isn't it? So when do we suspect inflammation? It has to be acute, it has to be progressive, but if it is, let's say, if it is not, if it is very, very, very severe in the first presentation, we always think of other causes other than MS itself. All right. But the key thing is that we have to keep an open mind when assessing any patient. Now, let's say if it is a rather subacute or insidious progression, then what do we think about? We think about other causes, isn't it? We either think about whether it's a space occupying lesion that is causing a compressive, pathology, or whether this could be a vascular malformation that is happening over time slowly, or it could be even metabolic causes like vitamin B12 or copper deficiency. And it can be even, so sort of secondary to really, really slowly progressive infections. Like there is a particular condition called tropical spastic paraparesis that is also technically a myelopathy that is associated with spinal cord inflammation, and it can be seen with this virus HTLV1. So there is quite a few things to consider, but the most important thing is that we have to keep an open mind, think about other differentials, and immediately refer to the expert so that we have an understanding of what this lesion could be. Now, in terms of how a patient could present in the context of inflammation, it can be a flare-up of MS or it can be a first presentation. And in the cases of, let's say, NMO or MOG disorder, anti-MOGAD disorder, the difference between the MS presentation and NMO or MOGAD is that in MS, it's generally, this is the key thing, it's generally less than 3 levels of inflammation that is affected. But on the other hand, if it is NMO or MOGAD disorder, you'll have greater than 3 levels affected, and it's much more severe. There's a rapid deterioration, and it is quite worrying, unfortunately. And there'll be really bad bladder and bowel dysfunction on presentation as well. And the recovery is quite poor as well. And you need to treat them urgently in these cases, especially if it is NMO or MOGAD. In general, when you get an MRI, that's the key thing that we are looking for. How many levels of inflammation is there? Now, an LP is really important over here, and you might see some lymphocytes on the CSF, and you'll have high protein as well. But like I said, if you see a large number of lymphocytes, always think whether could it be an infectious pathology. And in these cases, we'll have to get in touch with the microbiology department, revisit the travel history of the patient, try and see if there's any particular risk factors, and then think about what could be the cause over here. And always send oligoclonal bands if you're suspecting first presentation of MS, or even if you suspect a transverse myelitis. It's important to sort of send this so that we can predict the risk of getting MS later. Now, when there's no preceding history of infection, it might be a presentation of MS or NMO. And transverse myelitis is sometimes associated with a conversion of MS in typically less severe cases. And it's almost always less severe, like I mentioned earlier. Now, the key thing is that, in these acute severe presentations, you have to really give steroids. And if it is really bad, as in the case of NMO or MOGAD disorder, it's important to give plasma exchange as well. Now, the idea is that this is an antibody-mediated disorder, and you have to get the antibodies out of the system. And it's like dialysis, essentially. You exchange the, use this particular dialysis machine to remove the load of antibodies from your body, and then you recirculate it so that you get rid of all the antibodies that's causing this acute inflammation. That's the important thing. So in general, early escalation to the appropriate teams and starting treatment early is really important in these particular cases. Now let's go into the depths of MS and why we need to really talk about it in detail. Now, it's one of the most common causes of non-traumatic disability in young adults, especially in Europe and USA, and it's an immune-mediated disorder of the CNS. And the mean age of onset is quite 20 to 40 years, and there's a higher female to male ratio in terms of those who get it, and it can lead to significant physical disability. And although physical disability is talked about in MS in detail, what we don't often talk about is the cognitive impairment that comes with MS and with the burden that accumulates over time. With the lesion burden accumulating over time, there's a higher risk of volume loss, atrophy, and cognitive impairment. And that is something that really affects these patients a lot. And there's a reduced quality of life because of that. So in general, there's a reduced life expectancy by 7 to 14 years once you've had a diagnosis of MS. Now, what are the risk factors? So to be honest, we don't really know. There are some modifiable risk factors like smoking, obesity, sunlight exposure, and vitamin D levels are associated with, sort of vitamin D being low is associated with MS, having MS potentially, but it's not set in stone essentially. There's a lot of people with low vitamin D, poor sun exposure, they don't get it. So there are genetic factors which are non-modifiable, which you don't know, which we are not really sure about. And there is some association with EBV infection, and that's why there's some active research going on as to whether EBV vaccination could prevent MS in the future. This is something to watch out for. This might come out in the maybe next 5 years or so. Now, what is a pathogenesis essentially? Now, as I mentioned earlier, it is an autoimmune disorder of the CNS. It affects the brain, it affects the spinal cord, affects the optic nerves. Now, the ultimate damage is done at the level of the nerves. Now, we got this nerve sheath covering called the myelin, and then it causes this demyelination of the nerves, causing reduced speed of the nerve conduction essentially. Now, how does it work? So basically, the understanding is that there's sort of impaired blood-brain barrier permeability. There's entrance of the T cells and the B cells. There's interaction with the T cells and the B cells over there. And then these cells sort of release a lot of, induce the release of a lot of cytokines. And then there's activation of this inflammatory response, which leads to damage to all these neurons through demyelination. Now, this can be quite devastating if it happens over time, and the process happens slowly over a period of time. So it's not always very straightforward to manage these patients because of this. So now let's talk about the different clinical phenotypes of MS. So now the classic phenotype that you see, and the most common one, is relapsing remitting. Now, the reason why I've mentioned about this particular clinical pattern, these diagrams of this particular clinical pattern, is to help everyone understand how different, even the relapsing remitting MS can be. So now you can see in the second diagram, there is disability being sort of accumulated over time. And in the first diagram, there's no disability. So so let's say I'm a patient with MS. So I was diagnosed in 2019. So I had my first attack then. And I've had, sort of changes and whatnot to classify the case description of MS. And I have another attack in 2020. And when my MS consultant asks me what's happening, I say that, oh, my walking is getting worse, my symptoms are getting worse, whatever it is, and I'm feeling much more weaker or in between attacks. So that can be one of the big problems. You're accumulating new disability, and it can become a problematic situation. Now, there's another pattern of MS that can happen eventually that is called secondary progressive, which is the next most common. So what tends to happen is you have relapses over time, and then you just start progressing continuously. And the key thing here is that once you get a label of secondary progressive or primary progressive, things are generally quite bad. There's not a lot of treatments that can be offered, unfortunately. There are some licensed medications coming out for secondary progressive and primary progressive, but in general, it's a poor prognosis. Now, how do you diagnose MS? So obviously, the whole game in neurology it's about history and examination, and the rest of it is just to support our diagnosis. Now, there is a story that is consistent with the neuroinflammatory presentation. There are symptoms and signs of it, and there's abnormal MRI that is correlating to the signs. And these two things are quite important: dissemination in space and dissemination in time. Now, I used to get quite confused when I was a med student or a foundation trainee about, when somebody used to tell about this. And this criteria was updated recently in 2017, about 6 years back. Now, what does it mean by dissemination in space? So let's say that I'm presenting with MS in 2023 with my first clinical attack, and I have multiple lesions on the MRI. Then that sort of fulfills the criteria for dissemination in space. Essentially, it means that I've had subclinical attacks in the past, which obviously I have not presented to the hospital with, but MRI as a modality, imaging modality, has helped us understand, whether there is evidence of attacks in the past by looking at, a snapshot, and that's very, very useful. Now, what does dissemination in time mean? Now, let's say I presented in 2021 and I'm presenting in 2023 or 2022. That is a second clinical relapse. So now that is dissemination in time. Now, what else could help us understand whether there's dissemination in time? Now, let's say this is one of the reasons why I give MRI, we give contrast with the MRI brain to see that if there is enhancing lesions on the MRI. So the idea is that if there's enhancing lesions, these are active lesions. And that sort of classifies sort of fulfills the criteria for dissemination in time. And also, if you do a lumbar puncture, if there's evidence of positive oligoclonal bands, that can also mean, dissemination in time. So if you fulfill these criteria, then you have been diagnosed with MS essentially. Now, again, like I said, in terms of objective evidence for lesions in the past, neurology has come a long way from the first time MS was sort of, diagnosed in the late 1800s by Charcot and team. Now, it's not just reliant on abnormal examination. You see a previous lesion on MRI. You can do some other testing as well. Like, for instance, you might see a lot of neurology consultants arranging visual evoked potentials, somatosensory evoked potentials, or optic coherence tomography. Now, these are so visual evoked potentials and somatosensory evoked potentials are neurophysiological testings that are available to see if there's any evidence of slowed conduction that could indicate a damage in the past. Now, we're looking for historic lesions through these abnormal testings, essentially. If there is an abnormal VEP, then we know, there is a potential likelihood that this patient has had some form of inflammation of their optic nerves. Now, if there's an abnormal somatosensory evoked potential, we know, there is some form of inflammation of nerves in the body that has happened in the past, indicating that there was inflammation. And what is optical coherence tomography? Now, this is just to see if there is thinning of the retinal nerve fibers. Now, it's like looking into the brain, essentially, because optic nerve is the only nerve that you can look through the eyes. And it's a beautiful way to think about it. It's the only cranial nerve that we can look at directly under direct vision. And if we see if you look at the optic coherence tomography images, you can actually see the thickness of the nerve fibers of the retina. And if there is thinning of the nerve fibers, that is indication that potentially there must have been attacks in the past. So these are all objective evidence, and a neuroinflammatory consultant uses these evidence to diagnose MS in patients. All right. Now, let's say what is a feature of an MS relapse. So now, usually these are seen in younger patients, in young adult patients normally. So it's an acute onset, sort of evolution over hours to days, like I mentioned earlier. And you can have focal or multifocal symptoms, and it is persistent rather than intermittent. Now, why is that key thing important? That persistence of symptoms, because what could it be if it is intermittent symptoms? Now, let's say I'm a 23-year-old man coming to the ED and saying, I've got a headache, I've got some left eye visual disturbance, I can't see from my left eye. And with my headache going away, it could completely go away. My visual disturbance gets completely better. And so what could it be, really, at that point, And I also give a history that this has happened to me in the past, 6 months back, that I had a headache and my left-sided vision goes away completely with the headache. and it just gets better once the headache gets better. And the headache is coming on quite gradually. It is associated with nausea, vomiting, photophobia, phonophobia, you know. So in that case, it doesn't really fit with this sort of description, isn't it? It's probably a migraine, the way that I'm describing it. So that's the thing. History is really, really important in neurology because of that. Now, usually the duration of these symptoms lasts greater than 24 hours. It's never less than 24 hours. And it can take sometimes several weeks to completely get better. All right. And symptoms improve spontaneously in a true MS relapse or a first relapse or a first presentation of a clinical isolated syndrome. If it is MS relapse, if it is progressing beyond those several weeks, then we have to think about another progressive etiology. Now, what's this Lermite's phenomenon? Now, the idea is that, this is one of the ways that MS can present for the first time. So when you flex your sort of neck, if there is a cervical lesion, when you flex your neck, then what you see is that you can see the sort of sharp pains and, coming down, sharp pains going down. And that's one of the things that you can sometimes see. Now, why have I mentioned about trigeminal neuralgia over here? In which circumstance do we suspect if there is if this could be potentially MS, if there's trigeminal neuralgia? Can anyone write in the messages over there, in the chats over there? Can anyone tell me why have I mentioned trigeminal neuralgia? When do we think about this? So if a young patient is coming, especially with bilateral trigeminal neuralgia, then we have to think about MS. And spasms can be a feature of MS as well. So I think it's really, really important that we keep an eye out for these kind of symptoms. Now, let's say, what are the other clinical manifestations? And like I said, there's optic neuritis, which is a clinical phenotype or presentation. It could be a brain stem syndrome. Now, it could be a partial cord syndrome as well. And remember, the key thing is that it has to be a partial cord syndrome if you have to think about MS. Because if it is involving more than 3 spinal cord levels, then you have to think of other etiologies. And it's really important. Now, what are some of the red flags that makes us suspect another etiology other than MS? So the age of onset is quite odd, like less than 12 or greater than 60 years. Patient is of Afro-Caribbean origin, or like I mentioned earlier, if it's rapidly progressive, sequential, bilateral optic neuritis with severe pain, and there's no response to steroids or recurrence immediately after giving steroids, then we have to think of, something else. Or if there's focal cortical symptoms, like, there's almost presenting like a something, focal features like, visual field defects, dysphasia, arm or limb specific focal arm or limb weakness. It can be quite odd for MS to present just like that. Or even if there are seizures, it can be quite odd. So now, what is CIS? The concept of CIS is that it's called clinically isolated syndrome, and it's an acute or subacute episode of neurological disturbance due to a single white matter lesion. Now, remember, the key thing to remember is that CIS is often the first presentation in most MS cases. And if you have abnormal MRI lesions, in the next 10 years, there's a chance that's almost 60 to 80% chance that you're going to get MS. You're going to have a diagnosis of MS. Now, if there's normal MRI, absolutely no lesions, probably one single lesion, like sort of in keeping with the CIS presentation, then there's a 20% chance. So it sort of, predicts your risk of getting MS as well. And this is often the way you see patients present to the hospital, to the ED. And it's really important that you recognize it and recognize the pattern of presentation. The history is key, the examination is key, and the imaging is key to understand whether it is correlating to the history and examination findings. And then we can make a diagnosis of CIS. Now, let's look at some of the images. Now, these are just different images to demonstrate how MS can present. And as you can see on the first image, there's some optic neuritis that you can see on the right-hand side over here. And then there's a bit of a brainstem syndrome with a cord involvement. And then there's another brainstem syndrome over here. There's another brainstem syndrome over here. So all these are some of the typical, MS sort of presentations. Now, in atypical presentations, it's important that you sort of apply the McDonald's criteria with caution. And when are these atypical presentations sort of problematic? If for the patients as well, it's quite debilitating. So if you have severe bilateral optic neuritis, or if it's a complete transverse myelitis, like let's say it's involving like 8 spinal cord segments, or there's focal cortical symptoms like I mentioned earlier, or seizures, then you have to think about other reasons for reasons for sort of the patient's condition essentially. Now let's say a hypothetical scenario over here. Now I want all of you to think about it from a McDonald's criteria point of view, and think whether could this be MS or something else. Now there's a 70-year-old. Now that itself is odd. Age greater than 60. Remember the first red flag. There's bilateral sequential painful loss of vision. And that itself is odd, isn't it? It's not unilateral like you would see in a typical inflammatory MS-based optic neuritis. It's bilateral. It's sequentially happening. That's odd. It's painful. That's odd. Loss of vision, painful loss of vision over 5 days, rapidly happening, rapidly progressing. Visual acuity is decreasing significantly. And what do you see there? Oh, there's bilateral extensive optic neuritis. It's pretty bad actually. And there's a longitudinally extensive transverse myelitis. You can see over here, there's 1, 2, 3, 4, 5, 6, 7, nearly 7 spinal segments involved. Now that's all odd, isn't it? So I think, could this be MS? No, it's not MS. It's probably NMO, and we'll talk about NMO in detail, because NMO can present like this really, really bad manner, with a very, 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 very acute presentation can be there. Now let's go to the let's take another hypothetical scenario and say whether it's MS or not. A patient complains recurrent episodes of vague visual symptoms, followed by some mild left-sided weakness and headaches. And the patient says that just before the headaches start, I see some visual auras like this. And somebody does an MRI brain, and there are some patchy white matter lesions over here. Now, is that MS? Recurrent episodes. It's not persistent. Vague visual symptoms. Some mild left-sided weakness that is potentially sort of very mild, and it's not in keeping with the lesions essentially, and it's not correlating. So you need clinical correlation, you need radiological correlation. None of that is happening, and this patient has got headaches as well. So it's unlikely to be MS, isn't it? It's most likely migraine, and in migraine you can see these sort of patchy white matter changes, and these are not typical of MS as well. Now let's go back to our case. So our case, with our first INO presentation, there's a lesion in the pons there that explains the INO presentation as I showed earlier. Now the rest of the brain, with contrast, as you can see, there's a bit of enhancement, and there are other periventricular changes that can be seen in MS. And I'm not going to go into the details of radiological findings. Essentially, there are multiple lesions, all right, and it is correlating with the patient's symptoms. Now, what do we need to do? We need to treat the patient, isn't it? So there is evidence for dissemination in space, a dissemination in time. It is a classical first presentation. So now we need to start treatment. Now we need to talk about what are the treatment goals in MS. What are the treatment goals? Essentially, the treatment goals is that, we need to prevent any further relapses, because like I said, there is a concept that, you accrue disability in between these relapses, and you need to have, you need to prevent any further disease activity by avoiding any further sort of lesions on the MRI essentially, and the idea is that you need to prevent brain volume loss and prevent the patients from getting dementia or accruing any further disability. All right, so that's the treatment goal. So prevent relapses, improve the recovery, and no further lesions. So if you read about new studies in MS, there's a concept called NEDA, no evidence of disease activity. That's our aim. That's our ultimate aim. And all these MRI parameters that I've mentioned here is to prove that, is to show that. Now, what are the key things in management? See, ultimately, these can be complex management decisions, and it's important to sort of refer to the right specialist. And as neurologists, even general neurologists don't tend to do the management. It's almost always done by a neuroinflammatory consultant, and the neuroinflammatory team does the management. Now, there's one other concept that is very important. You have to phenotype the illness correctly, because the evidence base is poor for a lot of therapies like primary progressive or secondary progressive. So it's important that we classify the disease activity and classify what type of MS it is as well. And there are 2 kinds of therapies available. So there's one called immune reconstitution therapy, and there's one called maintenance therapy. Now, if you go back to the slide of You sort of remember the slide that I mentioned about T cells and B cells sort of crossing the blood-brain barrier, inducing inflammation, and causing a lot of damage to the myelin sheath. The idea behind immune reconstitution is to wipe out the immune system completely. So there are T cell depleting agents, there are B cell depleting agents, and then there's something called as stem cell transplant as well. Now that's only used in really, really bad MS with really highly active MS with rapidly progressive features. Then you think about stem cell transplant. There are maintenance therapies with all these drugs can be used, and it's case to case decision ultimately. Now these are some of the sort of drugs that can be used, and I don't want to go into the depths of it as such. Now, the key thing I want to mention is that, see, as you go down the ladder of relapsing, remitting, and then you think about secondary progressive or primary progressive, the options decrease. So, if let's say the patient is not really responding well to treatment, then we have to consider this diagnosis, and obviously this will have to be made by the neuroinflammatory consultant, and it will have to be an MDT decision as well. Now, what's rapidly evolving MS? It's there are various subtypes of MS, like I mentioned earlier. I'm not going to go into the depths of it. So it can either be inactive, can be active, or can be very, very, very highly active. Now, when you call something as rapidly evolving MS, you need to have two disabling clinical relapses and significant MRI activity in the last 12 months or so. Then in that case, you have to think about really intense treatment. Like, these are quite nasty drugs. Talking about alemtuzumab, cladribine, and natalizumab. All of them can cause really bad side effects, and it wipes out your immune system. It makes you washed out completely, makes you at risk for a lot of things. So this decision is made only if there is evidence of rapidly evolving MS. So now in terms of prognosis, generally there are some patient factors and paraclinical factors. Now, if male gender is generally associated with poor prognosis, later age of onset, it's poor prognosis again, and a high number of attacks early on in the diagnosis, it's associated with poor prognosis. And there's a short inter-attack interval that's also associated with poor prognosis as well. Now, in terms of other factors, if there's a lot of MRI disease activity, that makes sense, isn't it? That is associated with poor prognosis. Now, if there's positive evoke potentials, this is another reason why we do the evoke potentials. It is also associated with really poor prognosis, unfortunately. So now, when do we stop the disease modifying treatment, like we mentioned earlier? Now, if there's no response, basically it just means that there's no point in continuing it. So you're not helping the patient at all by giving something like this. Or if there's no reduction in the frequency or severity of the relapses, then we have to just think about stopping it. And the patient is just getting immobile completely, you have to stop it completely. And if there's a confirmed secondary progressive disease, then likelihood is that you might have to stop the treatment for these patients. Now, it's important that these MS patients, there is a significant change in the architecture of their brains that happen over time. So when a patient says, "Oh, I have a relapse," it's important to sort of understand and piece out whether they have a pseudo relapse or not, because oftentimes you can see this patient getting admitted through ED who has an established diagnosis of MS, and the concept of pseudo relapse is that your body's sort of systemic milieu changes completely, and then you get a relapse of your old symptoms. Now that's the sort of decompensation that's happening, for example, in the context of an infection or so. And unfortunately, with their architecture changing, their neuropsychiatric profile changes, and you can see functional symptoms quite commonly in these patients. And bladder symptoms can be problematic, and it is important to refer them early if they have continence problems or anything like that. If they have spasticity, it's important to treat it with supportive medications. They can have really bad sleep problems. Again, remember, MS affects the whole brain, and over time there's atrophy happening, and it's really important that we help them with these with sleeping pills or things like melatonin if needed. There can be problem with focus and concentration, and you can see this oftentimes be given to MS patients like drugs like modafinil. It is important that there is an understanding needed that there is a psychiatric change, there's a neuropsychiatric change happening, and it's important to be empathetic to the patients about these problems. Now that's a lot of talk about MS. Now let's talk about NMO very briefly. Now again, like I said, it's important to understand that, MS, NMO, MOGAD, and all these are very different disorders, because in MS, oftentimes you don't see an antibody that is sort of detectable. We haven't found anything that is detectable so far, let's put it that way. And on the other hand, in NMO spectrum disorder, I think in the year 1984, we found an antibody called aquaporin 4. And now the interesting thing about aquaporin 4 is that there are certain areas in the brain where you can see aquaporin 4 a lot, and that's where the lesions happen. Like, for example, in the optic nerve, or in the spinal cord, or in the area postrema region. Now, can anyone tell me what area postrema region and what it does on the comments or messages there? And why is that region quite interesting and important? Now, that region is also known as the chemoreceptor trigger zone. It's around the, sort of the base of the medulla and the fourth ventricles. So that's associated with nausea and vomiting. So you can have a patient presenting with intractable nausea and vomiting, and that can be an area postrema syndrome. And oftentimes, the biggest difference between MS and NMO spectrum is that MS, oftentimes, the patient is all right, it's not doing too bad. There is disability, yes, but it gets better. There is hope. But in NMO, things are quite bad from the beginning itself. It's quite severe. It's quite a severe presentation. And imagine, you have an extensive cord lesion in your spinal cord. Obviously, you get a spinal cord syndrome, an acute sort of myelitis. You are in spinal shock. You may even need ICU, and you might need active treatment to get these antibodies out of the body, because there's a high burden of these antibodies and you need to get them out of your body. And that's why you give very active treatment like plasma exchange, rituximab, or steroids. It's really important that this is really, it's really done much early, as soon as possible. Now, there's no particular geographic distribution, unlike in MS, where you see it a lot in in the European population, and in UK as well. You can see it in Scotland for some reason a lot. MS can be seen, but in NMO, I think it can be seen everywhere in the world. Some studies say that it's more common in the Afro-Caribbean and African population. I'm not so sure about that. It's all very biased studies, essentially. But the key thing here is that aquaporin 4 is highly sensitive and specific for the disease. So in the absence of aquaporin 4, so anyone would be quite cautious about diagnosing someone as a seronegative NMO spectrum disorder. Right now, in terms of management, you manage them with steroids and plasma exchange, like I mentioned earlier. And relapse prevention is really, really, really important in this particular case, because you have to follow them up and you have to start them on a steroid sparing agent, ideally quite early on. And the key take home message I want to tell everyone is that they present quite acutely, and they need early imaging. They need early referral to ITU at times, and they need early, sort of referral to an appropriate specialist, that is a neurologist or a neuroinflammatory specialist, and early initiation of steroids if you suspect this. And it's really important that, I think it needs to be done as early as possible so that we prevent any morbidity or mortality for the patient. Now, in terms of MOGAD, it's a bit less sort of dangerous than NMO spectrum, but it is associated with optic neuritis, transverse myelitis. And the key thing here is that, it can cause this non-compressive cauda equina-like syndrome, and it can also cause, sort of focal cortical lesions as well, and brainstem lesions as well. So the key thing here is that if you diagnose, a MOGAD disorder, now the full form of MOGAD is myelin oligodendrocyte. So if that is diagnosed, then, and if you have a antibody positivity, there is a high likelihood that you're gonna relapse again. So it needs good treatment, sort of, again, relapse prevention treatment, just like in NMO spectrum. And unfortunately, it's not very clear how to go about treatment in these particular conditions. And it's really important that, they be followed up, and they be initiated on treatment quite early as well, because they can also present quite drastically, but not as drastic as NMO spectrum. And the relapse prevention involves similar treatment like NMO spectrum, like rituximab, azathioprine, or mycophenolate. Now, what's ADEM? Now, the thing with ADEM is, you don't quite see oftentimes in adults. Now, it's really common in children and young adults, and it's oftentimes a para-infectious or a post-infectious demyelination that happens, and it's very monophasic oftentimes. But the important thing as a new doctor or as an SHO to remember is that these patients can present quite drastically, quite severe, in a quite severe manner. They present completely obtunded with a low GCS, and they'll have multifocal signs depending on where the lesion is. So they'll have signs that you can't really pinpoint to one particular location. That's quite worrying. And then once you get the neuroimaging, you see that there's a lot of blotches of sort of T2 white matter lesions. That's not very specific. Then you have to really be worried about this. So it's important to get sort of lumbar puncture done early in these patients, and they might even need sort of ITU admission early on, because mostly the treatment in ADEM is very supportive. The steroids have some benefit, but it's all very supportive treatments, unfortunately. And very rarely ADEM can be a first presentation of MS, and it's almost like it's not a thing actually. So it's important that if they present with something else in the future, we'll have to have a careful discussion with the MDT and have a serious consideration for other diseases as well before we make a diagnosis of relapsed ADEM or something else. So I think that pretty much sums up my sort of overview of different neuroinflammatory conditions. Is there any questions at all anyone would want to ask?
There was one, and I thought I would leave it to you. Is fibromyalgia commonly confused symptom-wise, as we are still fairly unknown regarding its etiology?
So I think fibromyalgia needs sort of a formal diagnosis by someone who's used to diagnosing it, first of all. And also there needs to be this particular pinpoint pain syndrome that is associated with fibromyalgia, and it's almost always difficult, and it's not oftentimes you don't see the MS pain syndrome. If you're worried about the MS pain syndrome, or if the question is based on that, is oftentimes a central pain syndrome. And remember one thing, the central area for pain modulation in our brain is the thalamus. So if you have an MS pain syndrome, that will be presenting in a very sort of typical hemisensory manner, and it can be quite intense as well. Neuropathic pain can be quite intense. So fibromyalgia pain would be quite different from the MS pain, if that's the question. And I think, although I wouldn't really consider MS in anyone presenting with fibromyalgia as such, unless there are other features to suggest MS as such.
I can't see anymore. I will talk very quickly. If you fill out the feedback, which I've just dropped in the chat, you will get a certificate for attendance that you can use. That you can use to demonstrate that you have attended some teaching at 7 o'clock at night, which is very committed of everyone. Thanks, Ameen. That was really good. I mean, they've all been really good, but that was really, really good.
I mean, I can still take questions if needed. I don't know. I mean, so I don't think there's any microphone allowed, isn't it? So they'll have to just type in the questions.
Yeah, exactly. They'll have to type it. Okay. We'll give it 30 more seconds, and if there is no more questions, we will drop offline. But yeah, I'd say thanks very much for coming, everyone. You can access, I think, the Parkinson's one we still need to upload, that you can access all of our other 11, I think, talks on things you need to know for neurology on that YouTube channel that I've stuck in the chat. They're all delivered by registrars. They're all some of the best teaching I've certainly ever seen at undergrad level for neurology. And yeah, until next time, I'm not sure when it is. I'm not sure if I will be the one leading it. But until next time, keep an eye on the Mind the Bleep social media channels and the website for more and more content. And we have no more questions, so I will drop us offline.